Welcome to today's webinar. I am Carla Cohn, and this is Pediatric Dentistry Emergency Procedures for and from the general practitioner. And I am a general practitioner. I'm limited to just doing some pediatric dentistry. I've been doing that for my entire career, which is about 29 years. And so I do it because I want to and because I love to. And this is going to be some of the procedures that I have found to be invaluable that I think are going to be very useful to you all during this time of pandemic, but also moving forward, these should be procedures that you keep in your armamentarium to do minimally invasive, good dentistry for your pediatric patients. So I am in Winnipeg in Manitoba, central Canada. We are about to open up our practices to what is normal dentistry, or our new normal dentistry, on Monday. Today is Thursday, so it's coming up fast upon us, and we are busy planning how we are going to make that all happen for our staff, practice, patients, and everybody involved. If you want to get hold of me, that's my email address. It's drcohn@shaw.ca. So if you have any questions or any comments, you can send me an email. I'm happy to hear from you all. And that is my website below that, drcarlacohn.com. That's got some resources on it, some procedure summaries, it's some protocols throughout some articles that I've written. Everything that I do is clinical dentistry, and all of the articles that I write are clinical articles. So you can see some articles on today's procedures you'll see in there, and one in particular I'll give you at the end. I haven't had a chance or the staff to put it up onto my website yet, but you can get that direct from SDI. So I'll give you the article that is relating particularly to what it is that we're talking about in today's webinar, towards the end of this webinar, in particular at the final end of this. Catapulteducation.com is the speakers bureau that I am a part of, and this is a group of dentists that go out and teach. And to the pandemic, we went out and we traveled and we taught. Now we're all doing almost everything online, so it's a new world for education, as you all know, because you're tuned into this as well. And underneath that is the American Academy of Pediatric Dentistry website. So that has a ton of resources for pediatric dental clinical protocols, recommendations, articles, anything that you might want to have access to. So you can feel free to go on that. Some of that access is in a restricted area. You need to be a member, but much of that information is available to you at just free of charge. So feel free to go on that and check that out. It's a great resource as well. And below that is my internet Instagram account, and that is at Kids Dentist Carla. So I love to have followers, so please feel free to go ahead there and follow me there. This is a group of my Catapult friends, and this is my Speakers Bureau. So this group, as I said, goes out and gives continuing education, just like I do. I have several um, partners in my education, manufacturer sponsors that I work with. These manufacturer sponsors, partners, give me honorarium support for these lectures, courses, seminars, conferences, symposia to happen. And so I work with many different companies, not just the ones that you see up on your screen, but I do work with several others. Today's symposium is provided by SDI, Southern Dental Industries. So the educational support, honorarium support, is provided by Southern Dental Industries. And so I thank them for their support and for all of the support for all of the conferences and online seminars that I've given over the last 10 weeks since this pandemic began. So these are definitely times of adversity. They're definitely times of change. We really are discovering who we are and what we're made of with our 10 or 12 weeks of imposed self isolation, quarantine, all of the things that have happened to us all worldwide over the last several weeks are have been difficult, and they are making us think about who we are as professionals and what it is that we're going to do moving forward and how we're going to need to change in these times of change. And I don't think that the change that we're doing is necessarily bad. I think that some of the change that is happening is definitely a good thing, moving from a very invasive model of dentistry to something that has to become more minimally invasive, something that we want to create definitely less aerosols when we're working. And doing this and creating this type of dentistry is a learning curve. It is something that we are discovering as we're going along. And once we actually physically get ourselves into practice and into the role of delivering this type of dentistry, you're going to see individually that that's going to change for you as well. So we have a war, and our enemy is definitely invisible. We need to minimize the contact with this novel coronavirus so that we don't infect our patients and we don't infect ourselves and we don't infect our staff. And it was said to me very wisely just the other day that the aerosols that we are creating and the vapors that we're seeing in our practice, those that we can see are not the dangerous vapors. Those have large droplets. Those will fall to the floor in a very short period of time. It's the aerosolization that we cannot see that we create with our handpieces that is more of a challenge and more of a concern to us, because those hang in the air for more time, for hours, and those can be inhaled if we don't have proper protective equipment. So this war we have against this invisible enemy, the goal is to minimize contact so that we don't expose our patients, we don't expose ourselves, and we can mitigate that risk that this novel coronavirus has to us all. And so when we talk about what we're doing today in today's webinar and what we're aiming to do is we really want to have an emergency type of treatment that is focused upon minimally invasive caries management for our pediatric dental patients. So this minimally invasive management is designed in this webinar to give you modalities to effectively treat and slow caries progression, to arrest caries, and to place interim restorative treatment. And we're going to do that with a medicament called Rivastar, which is a combination of silver diamine fluoride and potassium iodide. We're going to do that with glass ionomer restorative treatment. I'm going to talk about pulpitis, and we probably won't have time to get into the trauma portion of today's lecture, but we can do that when we're together another time. So when we see kids that show up in our practices like this, that we know this never has to happen. Children never have to experience this type of decay or pain, and we never have to have our children go through this. And we want to be able to prevent this from ever happening. And I want to drive home the fact that throughout all of this that we're speaking of, our goal needs to be able to prevent this from happening, and also to drive home the fact that kids' teeth do matter. Pediatric dentistry, primary dentition, they're important for the growth and the development of the child, for the maintenance of space, for chewing, mastication, for patients' aesthetics, for comfort, for all of the the things that are important that will allow our child to grow properly and to maintain health. So kids' teeth are important. Kids are never boring as patients. They are always an interesting experience when we have children in our office, and we just need to know how to manage them. When we have kids in our practice, we often look at the risk assessment tool for behavior, which determines our treatment options. What that means is that we look at the behavior of a child, whether that is from the age of the child, the temperament of the child, or so on and so forth. And then that is going to determine what it is that we can do. So if we have a cooperative, even-tempered child, we can go ahead and we can do treatment on that child in an effective manner, and we don't need to worry about whether that child can sit still. But when we have a child who cannot sit still, for whatever reason that child cannot sit still, then we need to look at our materials and our procedures that will allow for treatment options that are less invasive. And that's no different than what we're doing now. And when we're determining what our treatment options are, except now this novel coronavirus is determining our treatment options. So what I mean by this is we're trying to minimize our contact with the novel coronavirus, and we want to not create aerosols. And so we want to choose treatment options that are less invasive, that are faster, that are easier, that are going to minimize the need for using our high-speed handpiece. This is an excellent article, and this article is found in JADA. And what that article is going to describe to you are all of the dangers that that dental aerosols have that are contaminated with bacteria, blood, virus, and those aerosols are
What
a
time
route
meeting?
for uh, for
10 minutes.
disease transmission. And so we want to be able to decrease the aerosolization that we have in our practices. What we're seeing now is a reaction versus the proaction. So the reaction is the reaction to the pandemic and how we are needing to modify our dental practices. What we really need to keep in our minds now is how to be proactive, and to be proactive so that we can determine that plan, because our experts are telling us that we are going to have a second wave of COVID-19, and we need to be able to be ready in our practices and for protecting our patient base from emergencies so that we can have an easier second phase of COVID-19. So traditionally, we drill, we fill. These are times of change. Alternate caries management really isn't a change for pediatric dentistry. We talk about alternate caries management for those patients that are pre-cooperative or uncooperative. And we have modalities of treatment that are things like interim restorative treatment, atraumatic restorative treatment, that are common in pediatric dentistry for this type of patient population. But now we are looking at doing alternate caries management because we don't want to create aerosols. And so we will look at alternate caries management, and we want to think about what we're doing when we get back to our patients, what we plan for our immediate future in this time of transition when we're getting back to normal dentistry, and how should this experience impact how we practice dentistry in the future. So I'm going to talk and teach about glass ionomers and resin modified glass ionomers and their use in this type of dentistry as emergency patients to get our patients comfortable. and back to function when we get back to our office. Glass ionomers are cements, they're dental restorative materials, and that's based upon the reaction of silicate glass powder, which is fluoroaluminosilicate glass, and polyalkanoic acid, which is the ionomer. These two come together, they're mixed together, and they create that ionomer, and that is an acid-base reaction. That acid-base reaction requires water, and so ultimately we have an ionic bond between the material, the glass ionomer material, and the minerals of the tooth structure. So this is significant because this reaction requiring water means that we don't need to have an acid etch step and a bond step. We have an acid base reaction creating an ionic bond that loves water, so we don't have to have a dry field either. That chemical bond to both enamel and dentin is very significant in the speed and the ability to do this type of treatment in an uncooperative patient, but also in a minimally invasive way. Glass ionomers, resin modified glass ionomers, have a thermal expansion similar to that of tooth structure, and so they're more comfortable materials to place for that patient's tooth, so that when the tooth expands, we have something hot or contracts, the material will expand and contract at the same thermal coefficient of expansion. These materials are biocompatible in that they uptake and they will release fluoride, creating a very good environment for the tooth structure that will help with mineralization and help against demineralization. And of course, as I said at the outset, these have decreased moisture sensitivity when compared to resin composite materials. And so they're hydrophilic as opposed to our hydrophobic composite resins. They will withstand blood and they will withstand saliva. And so glass ionomers come into categories. Pure glass ionomers, as you see here, these are self-cure materials. We do not need to set a light to these materials. They will cure on their own. They're bulk fill, moisture tolerant, and therapeutic. And our focus, of course, today is on the pure glass ionomer Riva Self-Cure from SDI. We're going to talk about using these in an interim restorative treatment, intermediate restorative treatment, interim therapeutic restoration. These are all the same thing, IRT, ITR, use in patients who are uncooperative or pre-cooperative traditionally for pediatric dentistry. We use them as a technique of buying time, so we're using them as a temporary restoration. In this method, we remove decay with a hand instrument or a slow speed rotary instrument and placement of material, such as this glass ionomer. For truly being minimally invasive non-aerosol, we're going to be using removal of decay with a hand instrument. And so in this case, where we have a very young child, primary central incisors with decay at the gingival margin, we remove as much decay as we can minimally invasively, and we place a pure glass ionomer. That way we can withstand saliva, we can withstand any blood there may be, and we don't need to remove all of the decay in order to have an effective restoration. We're planning to go back in a few months, 6 months, whatever the case may be, in order to go in and place something more definitively. If you want something that's got better aesthetics than a pure glass ionomer and a bit better longevity, not a bit better longevity, we look to our resin modified glass ionomers, which are primarily a glass ionomer, but have added resin materials and chemistry to increase and enhance strength and aesthetics. These are dual cure materials, and they again are bulk fill and therapeutic, bioactive. And again, our focus today is going to be on the Riva Light Cure from SDI, resin modified or resin reinforced glass ionomer restorative material. In this clinical case, where we had a pre-cooperative child and we had a caries area there, we want to clean out as much caries as possible. And this is our immediate post-operative with the Riva Light cure in there, a resin-modified glass ionomer. And then this is her 6-month post-operatively. So these do hold up very, very well. And we can have this to be quite a definitive restoration in time, again, depending upon how much decay you're able to get out, how deep the decay is. Clinical judgment, of course, prevails. And this is a very short video of an atraumatic restorative treatment. So atraumatic restorative treatment is going to allow us to place a definitive restoration. It's really the same as an interim restorative treatment. You can see the Riva Light Cure going in there. This is a bit of the Riva coat in order to just move our Riva Light Cure into place, make it a little bit less sticky for our instrument, and then a light cure. And so this will give us a definitive restoration, and that tooth will exfoliate soon. Incomplete caries removal. On the basis of studies cited in the review below in JADA, and this is from 2008, I feel I need to say because that is a 12-year-old study, there is substantial evidence that removal of all infected dentin and deep carious lesions is not required for successful caries treatment. So we've known for a long time that we don't need to have fully removed caries, fully removal of caries in order to have successful treatment, provided restoration can seal from the oral environment effectively. And so it's important to have sound margins when we are placing our, our incomplete caries removal type treatments. Before concept is accepted, additional clinical trials were needed. Well, then we have in another study later on in time, then this one is from, let me just see the date on here, is from 2018. I'm sorry, that was just blocked by my computer here. And within the limitations of that study, partial caries removal show high success rate in both primary and permanent teeth. So very, very successful type of treatment. This systematic review, though, is showing, this is important for you to remember, results show increased risk of experiencing restoration failure. And this is 2019 after selective caries removal of soft dentin. And that's because on a soft base, you have not a good foundation, let's call it, for our restoration, but we have a solution for you for that. And so I also want to point out this study that is showing us that caries removal is in a traditional restoration, we have very good results on class 2 restorations with a resin-modified glass ionomer, 3-year longevity primary class 2 restorations. We have lots and lots of materials and medicaments that we can use to prevent and arrest dental caries. But my focus today is going to be upon the Riva Star for your prevention and arrest of dental caries. So this Riva Star, we're going to talk about the best evidence using, it's a silver diamine fluoride material. Perhaps let me show you this before we go to that. This is Riva Star. It's a 2-step process of placement of silver, which you can see in the silver capsules, and potassium iodide, which you see in the green capsules. So a 2-step system. The Riva Star, the 2-step system, the silver fluoride and ammonia. The silver capsule is a 35 to 40% silver fluoride weight to volume with 15 to 20% ammonia weight to volume. And step 2 is the potassium iodide, which will minimize the black stain. So let's look at these studies. 10 clinical trials carried out in 6 countries with almost 4,000 children. This is from doctors Crystal and Niederman and published in 2016 in Pediatric Dentistry Journal. And that's talking about the best evidence for silver diamine fluoride, leading to a nearly 80% reduction when it's placed in both caries progression and subsequent caries on teeth. But we also have another article, Journal of Dental Research, 2009, showing the efficacy of a single application of 38% silver diamine fluoride in 6 months. So we have both the single use and a biannual use that are effective. This is nothing new. Back in 1920, 100 years ago, a G.V. Black 4th edition book on operative dentistry talked about placement of our silver nitrate, which was arresting caries. If there's any decay left behind, dentin exposed, treat it with silver nitrate. You crush it up, put it with an orange wood stick, and it's going to turn our affected dentin black. This is the same premise, the same as our silver nitrate. We've now become more sophisticated and have a better delivery system for our silver diamine fluoride, but the effective result is the same. If we're just placing silver diamine fluoride on our tooth's affected dentin, we're going to have a blackened area. So this is one of the adverse reactions of silver diamine fluoride, is that arrested caries appears dark brown or black. That's not aesthetic. We can't place it for patients with metal allergies, and we have possibility of gingivitis or mucositis. It tastes quite terrible, and if we do get it on skin or oral tissues, it will stain. That resolves within 2 weeks. So what to do about this darkened, unaesthetic looking silver diamine fluoride scar is SDI has come up in Revastar with the addition of potassium iodide. That potassium iodide, as I said, minimizes the black stain. So the silver used as a topical agent, we put it on with a brush. It arrests dental caries, simple to apply as a drop, no local anesthetic needed and no drilling required. And the potassium is used as a topical agent. It will minimize that stain. How does it all work? The silver diamine fluoride mechanism of action: silver acts as an antimicrobial, the ammonia is a solvent, the fluoride is a mineralization agent, and the potassium topical agent minimizes the stain. The potassium iodide will be placed after. The silver ion in there, the antimicrobial, denatures all cell proteins, breaks down cell wall, inhibits DNA replication, and acts as a coagulant, which denatures exposed dentinal protein, occludes the dentinal tubules, and then acts also as a hypersensitivity agent as well. So it feels good for the patient. Revastar's effect on strep mutans: the use of both silver diamine fluoride and potassium iodide is effective in reducing the number of strep mutans in dentinal tubules that are infected with that organism. The two together, the potassium iodide, will maintain that caries arrest efficacy. And we all know what fluoride ion does. That acts as a mineralization agent, creates fluorhydroxyapatite, and inhibits demineralization and inhibits bacteria. So the summary of the mechanism of action is the production of a silver salt forms a precipitate on the surface of the tooth. The permeability of the tooth surface will be decreased due to that blocking effect of insoluble silver apatite, and formation of sclerotic and calcified dentin will be stimulated. Use of silver diamine fluoride poses little toxicity of fluorosis risk when used in adults and children. We have a maximum recommended safe dose of 1 drop per 10 kilogram patient. Very important to know that silver diamine fluoride, Rivastar, is not to be used in direct contact with the dental pulp or pulpily involved teeth. So a tooth that has a pulpitis that you think you have going to have communication with the dental pulpal complex, we do not want to use this medicament on there. Silver diamine fluoride can penetrate. The silver and iodine don't penetrate more than 100 microns beneath the surface of the lesion, and that will provide a lethal barrier against further bacterial infection. Fluoride ions also pass more deeply into demineralized dentin at concentrations of almost 2%, and that will kill well beyond the lethal dose to bacteria of 2,000 parts per million required to kill that strep mutans. That is an article from Dr. Knight from the Oral Health Journal. So we do want to be aware that we're not penetrating to the pulpal tissue. Clinical photographs. This is Rivastar going into place on a cavitated lesion. Placement of the silver first with the silver brush creates a darkened area, and then immediately after placement of that Rivastar silver, which is what is here, that's placed for 1 minute, we place the potassium iodide. You'll see a creamy precipitate. You rub that in for 90 seconds, and that 90 seconds we're going to see a clearer precipitate. 1 year postoperatively placement, this is a different patient. 1 year postoperatively placement of silver diamine fluoride, we can see a silver scar forming. So very evident to see. Rivastar preparation, do we etch or do we condition? Comparison of etching versus conditioning here, and we can see that conditioning limits the penetration of Rivastar into caries dentin compared to a deeper penetration if we were to etch, rinse, and dry. So in an ideal scenario, etch, rinse, and dry. If we want to place this interproximally, what we're going to do is we're going to place it on a piece of superfloss, and we're going to place that interproximally. So we can place the superfloss, rub it interproximally for 1 minute. This we can see after. This is a post-operative silver diamine fluoride stain after one of those interproximal applications of our silver. So we do need to tell our patients that the silver is stained. In Canada, Rivastar is approved as a caries arrest agent, and so we can use that successfully in Canada without fear that it is labeled as something else, although off-label use is fine anyway. In the United States, which is probably not relevant for those who are watching, but maybe. The code for placing this is a D1354. A code for the placement of this in Canada is a 13600, and that is for unit of time. What you're seeing on the left side of your screen is our availability of what we have Rivastar right now. There is a bottle formulation that should be available in Canada soon. I'm going to use that in combination with our glass ionomer, pure glass ionomer that we spoke about in a SMART technique. SMART technique is a silver modified atraumatic restorative technique, which is the application of silver diamine fluoride, a traumatic restorative technique. SMART is the application of silver diamine fluoride, potassium iodide, followed by glass ionomer. In this case, this is a postoperative of the SMART technique, Rivastar placement, silver diamine fluoride, potassium iodide, followed by pure glass ionomer. In this case, we're talking about Riva self-cure from SDI. So what we have here is a preoperative photograph of the application of the medicament. This is preoperative. Pre-op, this is gross decay prior to removal. This is the gross decay excavated, and then we're placing our Rivastar, silver diamine fluoride, silver, and then immediate postoperative, followed by our potassium iodide and cream of precipitate, And now we are simply placing our pure glass ionomer, and this is our final of the two. So a very aesthetic looking final photograph, and we are not seeing any staining there. Now keep in mind too, depending upon the depth of the placement of our Riva star, if it's very superficial and we only have a thin layer of our glass ionomer, you may see some shadow or some staining coming through. But if we're deep, like this one is, then we are going to have a very aesthetic result. Pre-treating with Riva Star for our use of our glass ionomer is actually going to enhance the bond of glass ionomer to our tooth surface, and so it's a great way to enhance that bond by pre-treating with the glass ionomer. The ion uptake into demineralized dentin from glass ionomer cement following pretreatment with silver fluoride and potassium iodide, we see fluoride levels in the zone significantly increased. We see not a significant effect of the strontium uptake into subjacent demineralized dentin. So placement is an excellent idea before glass ionomer. Let's look at this case, a gross decay, removal of the gross decay, in this case the placement of the silver diamine fluoride potassium iodide Rivastar combination was so that we did not have an invasion of the pulp. So the silver placement followed immediately by potassium iodide after the 1 minute application. Potassium iodide now in for 90 seconds. So silver 60-second application, potassium iodide 90 seconds. Immediately post placement of the pure glass ionomer, and in this case we're putting a layer of a resin modified glass ionomer, the Riva Light Cure for example, over top, and then sculpt it, and our final. So this is a way of placing a sandwich. We can have prevention of secondary caries by placement of silver diamine fluoride, and an excellent way to prevent secondary caries conditioned with 38% silver diamine fluoride can increase the resistance of glass ionomer and composite resin restorations to secondary caries. And micro hardness of the dentin after silver diamine fluoride application. So that NUP hardness in clinically arrested dentin caries was more than 40, whereas in soft caries was below 10. So that's very significant. Let me see if I can give you that study one more time. I showed you initially when we started talking about incomplete caries removal. I showed you that there were susceptible possibly to failure because of the softness of the dentin. Here we are. And results show increased risk of experiencing restoration failure after selective caries removal of soft dentin. And that when we place the silver diamine fluoride and we increase the hardness of the dentin by placement of the silver diamine fluoride, we no longer have to worry about increased restoration failure because we have increased that hardness of the dentin. Let me show you a silver sandwich. I will show you a silver sandwich. I'll share with you a silver sandwich technique, and that silver sandwich technique is a combination of a co-cure technique. This was developed by Doctors Knight and Doctors McIntyre back in Australia. That is a placement of silver diamine fluoride potassium iodide, the Riva Star at the base of that restoration, followed by glass ionomer, resin modified glass ionomer, or Riva Bond LC as a bonding agent, and placement of composite. And what we do is we cure them all together, which is going to create a cascading effect, the shrinkage of the composite, and then the expansion of the glass ionomers and an increase in strength. So layer 1 at the base of that silver sandwich is Riva Star. The base is Riva Star. Layer 1 is pure glass ionomer. Layer 2, resin modified glass ionomer. Or you see here on the right side of your screen the Riva Bond LC. This is a Riva Bond LC is a light cured glass ionomer adhesive, which has low polymerization shrinkage, and that's going to bond the two layers together, the uh, Riva glass ionomer, the self-cure with the composite. Pardon me, a little bit of a um, not ability to speak there for a second. So we want to use the Riva bond will need to be triturated in a triturator, just like our Riva self-cure and our Riva light cure. So triturate, and then you can see the bond in the bottom. Here you can see, if you can see my mouse, you can see the Riva bond LC. Our third layer is going to be composite. This is going to give you a good definitive restoration. We can use either the SDI Aura or the SDI Luna Excellent Composites. Luna Universal is a composite by SDI. It can be used anterior and posterior. It has nano hybrid. It won't stick to instruments. It does have a very high flexural and compressive strength, 77% fill by weight, and has a lovely chameleon effect. So these are our layers of our silver sandwich. Do not get confused. We can do one or the other. We're not doing both. We're either doing the left side of your screen or the right side of your screen. Where at the very base, we have our Riva Star. On top of that, we have our Riva Self-Cure, and then either our Riva Bond LC or Riva Late Cure to glue in our composite, in this case, which will be either the Luna or the Aura. So again, this is what the cross section looks like. We cure all together, shrinks up our composite. The heat from that will cause our resin modified glass ionomer to cure and expand, our pure glass ionomer to cure and expand, and a nice cascading effect, which is going to increase the strength and the integrity of these materials. I will share with you one or two more clinical cases. This is recurrent decay in an old composite. Clean that up. Deep decay approximating the pulp, so therefore the choice to use the Riva Star, and in a smart technique, the deep decay. Silver diamine fluoride, place it, rub it for 60 seconds. Potassium iodide to minimize that dark stain. The placement of pure glass ionomer as our first layer. Don't cure it, don't wait for it to cure. Now our Riva bond, and I'm doing dual duty here. I'm placing my Riva bond on my enamel that is exposed, because I need to have some ability to place some composite to the enamel as well. I'm going to place a flowable over top of everything, you'll see in a moment, but also the Riva bond, which again is a light cure glass ionomer, to our pure glass ionomer, in order for that to glue to our next step, which is our injectable composite. Remember, we are not placing, we're not curing in between. I haven't cured anything. At this point, placement is complete. At this point, I'm curing. We have that cascading effect. A little video to share with you as well. So in our co-cure technique, a second case, excavation of gross decay, placement of our Riva silver, and then our potassium iodide to minimize that stain, 90 seconds. I've speeded it up for you. We can put our acid etch on at this point. It's a good idea to do double duty, because I do want to rinse that potassium after it's been placed. Pure glass ionomer, Riva bond, and then the Luna composite. Shape it, pack it as usual, and then light cure once we're happy with it. Placement of flowable composite. I like to put top coats on top of everything and seal everything up. Light cure again, and this is our final. So this article can be found through Denise, who can send you the link. I'm going to give you her email address in a moment. I wrote an article on that particular clinical procedure, smart dentistry it's called, silver modified atraumatic restorative technique, co-cure method. So she can provide that for you. Again, you're seeing the bottles here on this slide, but of course, either that or our single dose systems. So these are the all of the references that I have for this article are included here if you're interested in seeing that. So I think at this point, where are we at for timing? 8:48. I think at this point, this might be a good time to end today's webinar, giving you um, a good handle on those techniques. Let me just pull up my slide for you with the information that Denise has for you. There we are. So links to the webinar for those of you that are going to want to see this re-recorded. A copy of my article, uh, you can email Denise, denise.kaczynski@sdi.com. Underneath that, that's my Instagram account. That's at Kids Dentist Carla again. And so I think at this point we'll end it. We wanted to leave 10 minutes for some Q&A. I don't know if we have any Q&A. Denise, I'm going to put the end up, and I will let you tell me if we can
I
have any
don't see anything on the chat, but I will unmute everyone. As you know, I tend to mute folks when we do these. So are there any questions? This was great, Dr. Cohn. Thank you so much. It's always so great to hear you speak and for you to share what you're doing in your practice with us. And as always, thank you so much. It looks like you covered everything.
Okay. All right.
And thank you everyone for joining us today. We appreciate your time. And Dr. Cohn, thank you so much. Everyone be safe and take care.
Yes, I second all of that. Thank you, and thank you SDI for hosting this. It's an incredible amount of work to get this up and running, and I appreciate everything that you're doing, Denise and everybody all over there at SDI. Everybody stay safe, wash your hands, and life will continue as our new normal, and I'm hoping that we're going to embrace it. So signing off from my end, and thank you all again.
Thank you so much.